It's been more than a year since actor and comedian Robin Williams died, but new details shared this week by his widow are calling attention to a form of dementia that has received little public focus until now. William Brangham has the story.
After Robin Williams took his own life, his press representative said Williams was battling severe depression. His widow, Susan Schneider Williams, also said back then that he was struggling with depression and early stages of Parkinson's disease. But this week, Mrs. Williams told ABC News and People magazine that an autopsy revealed something else. He had what's known as Lewy body dementia. She described battling a mysterious set of symptoms for a year, something she compared to playing whack-a-mole. Quote, "They present themselves like a pinball machine," she said. "You don't know exactly what you're looking at. I've spent this last year trying to find out what killed Robin because we didn't know. He didn't know. He didn't know. He didn't know. He didn't know."
Hello, my name is Krista Nicole Davis, and I'm a mental health nurse practitioner student at the University of Texas at Rio Grande Valley. Today, I'll be presenting a case study on Mr. Estel to make a diagnosis of a neuropsychiatric disorder. First, we'll discuss the history of present illness on Mr. Estel. He is a 74-year-old male, and he presents with a multi-year decline that is remarkable for stiffness, forgetfulness, apathy, and also significant cognitive decline over a 9-year period. He also presents with cognitive deficits that interfere with his ADLs, which are his activities of daily living. He cannot remember his appointments, his medications, basic calculations, he is forgetful, and he cannot pay bills. He also has fluctuating cognition. He appears depressed, he acts apathetic, but he reports that he is fine. He also has recurrent visual hallucinations and also frequently falls out of the bed. He also presents with spontaneous features of Parkinsonism, which include right hand tremor and shuffling gait. Mr. Estel also went to see a physician, and the physician stated that Mr. Estel may have early dementia. He also began to lose interest in things that he would normally do, for example, playing cards, and he also appeared depressed. So now we'll move on to the diagnosis. So the diagnosis is a probable major neurocognitive disorder with Lewy bodies with behavioral disturbance, also known as dementia with Lewy bodies. The rationale for the diagnosis. Mr. Estel started to have a gradual cognitive decline with a rapid decline over the last year. He also had signs of inattention and depth perception, depressed mood, and apathy. Mr. Estel also met the criteria for a major neurocognitive disorder. He had symptoms not related to another mental disorder. He had recurrent visual hallucinations. He also has evidence of significant cognitive decline from previous level of performance. He also had interference with his ADLs, and this was not in the context of delirium. He also presented with fluctuating cognition. At times, he was almost like his old self, and then at times, he was like a zombie. He also had sleep disturbances where he would act out in his sleep. Spontaneous features of Parkinsonism were also present, which included right hand tremor, shuffled gait, stooped posture, and stiffness. And he also had frequent falls out of the bed, which are all part of the DSM-5 criteria. Differential diagnosis. The primary entity considered in the differential diagnosis for DLB is Alzheimer's disease. Other considerations include Parkinson's disease, also known as PD, vascular dementia, and other degenerative dementias and certain psychiatric diseases. In Parkinson's disease dementia, also known as PDD, dementia occurs in the setting of well-established Parkinsonism, while in DLB, dementia occurs concomitantly with or before the development of Parkinsonian signs. If Parkinsonism is present for more than 1 year before the onset of dementia, it is only classified as PDD. Now we'll move on to the evidence-based treatment plan. In general, the patient will need a mini mental state exam or some form of neuropsychological testing. He will also need a neuroimaging study, for example, an MRI, and also laboratory evaluations such as vitamin B12 levels and thyroid function studies. The management of patients with DLB is complex, requiring a multifaceted approach. Pharmacologic management for cognitive symptoms. Meta-analysis of Class 1 clinical trial of bristagmine and donepezil support the use of cholinesterase inhibitors in DLB for improving cognition, global function and activities of daily living, with evidence that even if patients do not improve with cholinesterase inhibitors, they are less likely to deteriorate while taking them. Neuropsychiatric symptoms. The use of antipsychotics for the acute management of substantial behavioral disturbance, delusions, or visual hallucinations comes with attendant mortality risk in patients with dementia, and particularly in the case of DLB that should be avoided whenever possible, given the increased risk of serious sensitivity reaction. In alignment with general advice on depression and dementia, selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, and mirtazapine are options in DLB with treatment guided by individual patient tolerability and response. For motor symptoms, Parkinsonism is often less responsive to dopaminergic treatments in DLB than in PD, and their use may be associated with an increased risk of psychosis, although some patients may benefit from levodopa preparations introduced at low doses and increased slowly to the minimum required to minimize motor disability without exacerbating psychiatric symptoms. Patients at risk of falling may benefit from safety assessments as well as bone density mineral screening and assessment of vitamin D status to manage risk of traumatic fractures. Patients also benefit from supportive and educational psychotherapy in which the nature and course of their illness are clearly explained. Clinicians can help patients find ways to deal with defective ego functionism, such as keeping calendars for orientation problems, making schedules to help structure activism, and taking notes for memory problems. And this concludes the case study on Mr. Estel. Thank you.